Hello, good afternoon. I'm Ardas Khalsa, and I'm the Deputy Medicaid CHIP Director for the Healthcare Transformation Waiver. And Chairman and members, thank you for the invitation. And actually, I'm going to go back to slide 18, and Pam is correct. The waiver started in the fall of 2011, but that is federal fiscal year 2012. So, of course, Pam is correct. With the current status of the waiver, we currently have 1,451 active district projects in the 20 regional healthcare partnerships, 298 performing providers that include both public and private hospitals, physician groups that are largely associated with academic health science centers, community mental health centers, and local health departments. And the major project focuses are behavioral health, over 25% of the projects, access to primary care, about 20%, chronic care management and navigation, 18%, access to specialty care, 9%, and health promotion and disease prevention, about 8%. And district, the target populations are both Medicaid and low-income uninsured for this program. Over $7.1 billion was earned through January 2016. We do have a payment going out later this month soon. That will be an additional $722 million, all funds and payments that are about to go out for the first payment for demonstration year 5 that we're currently in. So as Pam stated, and the Commissioner and Commissioner Smith, HHSC was required to submit a request to extend the waiver by last fall. And in September, we did request to include all 3 main components of the waiver, including the managed care component and the district and UC funding at the current. We actually asked for an increase in UC funding, and that we had made progress related to all 5 waiver goals, and we had proposed to make additional improvements to the program to support and strengthen the healthcare safety net. And Commissioner Smith is going to talk about the next slide, and then I'll come back. Yes.
Members, I just wanted to mention that, as you are aware, CMS has asked us to conduct an independent study, and so we have 2 vendors that are in the process of doing that. We will submit our a draft report on Friday that we received from the independent vendors, and then we'll submit the final report to CMS at the end of August. And so basically what they've asked us to do, and they sent us a notice in November of 2015 as we were going through the 1115 negotiation process, that they wanted us to conduct a study that basically is an evaluation of uncompensated care. They wanted us to report on the completed independent information. I guess I forgot to mention that our vendors are Health Management Associates and Deloitte Consulting are the ones that are conducting this review. Deloitte is doing a comparison of what other states have done in regards to this funding. And so we're going to be submitting what the role of UC and DSRIP is in those payments in our overall Medicaid system for paying hospitals. They also wanted us to consider the adequacy of those Medicaid payment levels, which Pam talked about before in relation to the Medicaid shortfalls, and indicate whether or not and to which degree the UC pools and the district payments compensate for insufficient base payment levels by the state. They're also wanting us to identify the percentage of the uncompensated care payments that are not specifically related to the Medicaid shortfalls, and so that they're going to be separating those out. And then they're going to define the uncompensated care cost as those associated with charity care. They want to separate that from just the regular indigent care, uncompensated care that's associated with those entities, and ensure that it's not included in the bad debt or in the Medicaid shortfall. And then finally, they want us to estimate what the Texas uncompensated care burden would be for federal fiscal year 2017 if Texas Medicaid rates, if Texas would have expanded Medicaid. They want to know how much would that reduce the uncompensated care costs for the state. And so that will be providing that information through those studies as directed.
Commissioner, will you elaborate how you expect this information, once it's compiled and presented to CMS, how will that be utilized, and what do you expect?
What I expect is that this information, once it's compiled and submitted to CMS, it will be part of the negotiation. I would fully imagine that they're going to take a look at the uncompensated care amount that we receive, as an example, this year, $3.1 billion. And they want to know if Texas would have expanded Medicaid, how much of that $3.1 billion would go away. They'll also want to know that if Texas paid the full Medicaid rate that Pam talked about earlier, how much again would that uncompensated care go away? And I will imagine that they would probably start trying to determine that if they remove that from the equation, then what does Texas have left? And that would be what they would probably attempt to say is the true uncompensated care amount for the state. They fully understand that the state has the option to expand Medicaid or not to expand Medicaid. But it sounds like, and it seems that what they're doing is trying to figure out that the state may exercise that option, but the federal government may not choose to fund it based upon the state option that is elected.
Thank you.
And on slide 24, we, as was mentioned, we do currently have a 15-month extension that extends to December 31st of 2017, and that in that agreement, both the Centers for Medicare and Medicaid Services and Texas will work now and during that time on an agreement to reform the state's UC pool and district pool. In that letter, there is a default methodology should we not come to an agreement. So if at the end of calendar year 2017, CMS and the state have not come to an agreement that is consistent with CMS's UC pool principles and a district program that supports Texas' commitment into managed care, district would not be renewed except as a phase down of 25% per year, and then UC would not be renewed except at a reduced level consistent with CMS's principles for uncompensated care. So we do currently, for district, we do currently have our mechanics in place for the period that starts on October 1st of this year. So the first 12 months of that 15-month extension, we do have our agreement now with CMS in place for that. And then that final 3 months, we would still be working on as part of the longer-term extension, and of course working with our leadership on that longer-term extension. But then Pam's going to talk about the UC part of the next steps, as well as some information on Florida.
And as Commissioner Smith mentioned, CMS has laid out the principles it is going to approach recalibrating the UC pool. And those principles are laid out in a letter in your packet. I think it's called UCC Pool Letter. In general, they're saying that coverage is the best way to ensure beneficiary access to health care, and that UC funding should not pay for costs that would otherwise be covered in a Medicaid expansion. They also think, under their principles, that Medicaid should support the provision of Medicaid services, and that provider payment rates should be sufficient to promote provider participation and access. Basically, their principles, when you put them all together, what they're saying is that they don't believe UC should include anything to cover the cost of the Medicaid shortfall or to cover the cost of providing care to uninsured individuals who would have been covered under Medicaid if a state had chosen to expand Medicaid. Florida was the first state to renegotiate its UC pool under these principles. So we included 2 slides about Florida. In a lot of ways, Florida is different from Texas. In some ways, it's the same. It had this thing called a low-income pool that was similar to our UC pool. Initially, Florida was granted a one-year extension to its pool. And Florida was required to have an independent study of its UC, very similar to the independent study Texas is working with its contractors on right now. At the end of the day, what Florida agreed to was a UC pool that did not include Medicaid shortfall and did not include costs for individuals who would have been covered under an expansion. Florida also was required in their calculations to use certain types of data, in part because they didn't have the kind of cost-based data that we have available in Texas. We're very confident in our data and its accuracy, and are hoping to be able to lay out and make the case for CMS that this data that we do have is data that should be used in coming up with this pool size, rather than the kind of data Florida was required to use. We're hopeful that that will help us some in getting the most robust UC pool that is actually justified for the state. So far, I don't believe any other states have finalized, except probably California has finalized theirs, but California is very, very different from Texas because it's almost all public hospitals in terms of their waiver and all.